And welcome. Again, this is Seamus Coffey here. This is our tertian for EC 4001. I'll do as part of the bridging program for the Economics Postgraduate Diploma. The target of this session is the concept of health in the macroeconomy. So in one of these sessions we've looked at some economic issues, we've looked at reasons for government intervention in the market economy. Today we're going to look at some reasons for government intervention in the healthcare market, and then look at some overall general macroeconomic issues in relation to the impact health has on the overall economy. So you can look at, again, I wouldn't you need to go for this straight away. Just a chapter from Tim Harford's book called Undercover Economist. Again, an excellent book if you're just looking for a broad oversight. If he does have one chapter to go to healthcare, the chapter is called The Inside Story, how the healthcare market functions, that emerge, and different solutions. In the chapter, Tim himself looks at Singapore health system and how they go about meeting the healthcare needs of their population. Healthcare market, is there a role for government? We saw there was a role for government in the overall market economy. What role for government is there in the healthcare market? And that's the overall. The key is market failures. So I'll actually look at 5 keys to the functions of markets. As we'll see when it comes to healthcare markets, these 5 keys aren't present either. So it'll be information, competition, third-party effects, trust, etc. That can be absent. And the presence of these market failures, where these foundation stone markets are absent, there is a role for government. But if it did not exist, the market for healthcare might ultimately have a role for government, simply because healthcare is a different product, different good, like buying a car or a television or a pair of shoes, etc. Such low income that they cannot afford adequate healthcare. Not affording adequate healthcare that you might die. Healthcare are different goods was purchased and consumed through markets. So there may be a role for government actually to provide to people who cannot afford it. The government can go around in general buying cars, televisions, or shoes for people who can't afford it. But the healthcare might be somewhat different, because it's a product that people actually need in one particular thing, not a matter of survival. But the healthcare and having a particular treatment may matter for survival. So health is different. So some people argue that health is different because they need it rather than want it, and might don't have access to it. But you can also view healthcare as having some properties that are referred to as public goods. The difference than private goods. For private goods, the price is generally the person who consumes the goods. So it be the case that the good is consumed by the person, they get the benefit from it. Healthcare, the benefit can actually flow to other people. So it can have public effects, where one person taking research can benefit other researchers. But if our healthcare is providing positive externalities, so used externalities in our last session, is there the party out of the transaction who benefits. So like a buyer and a seller, there might be a third party who's influenced. So healthcare is one negative externality, a buyer and seller, and a bystander might be influenced negatively by what's happening. So one positive externality could be, say, in vaccinations, that you buyer and a user of the vaccine, they benefit, the user, the person obviously benefits by being immune to a particular illness, but also benefit if the group proportion of the population get the vaccination. It is likely that that illness, that contagious disease, is spread through the population if more people are vaccinated. So there can be positive externalities, that if you're a room full of people and they're all vaccinated against a particular illness, well then you're less likely to get that illness. So if it spreads you, even though you mightn't have the vaccination yourself, everybody else is vaccinated benefits you, because this is less likely to be spreading. Be positive externalities where other people benefit from the condition of healthcare services by other people. So vaccination plays a role for government, and in Ireland we have numerous vaccination schemes for babies and young children, where the government undertakes the universal vaccination of everybody against particular illnesses. Because the benefits that are there of making sure these illnesses can't get a foothold in the population. The more people that are vaccinated, the greater and greater the benefit. And the benefit actually goes beyond simply vaccinating particular people. The benefit actually accrues to the population as a whole. There are a number of instances where government intervention in the market, in the health market, is warranted. So we have some of the market failures in the market for health. We came to the overall market. We introduced 5 keys, and you see these cropping up time and time again, looking at the overall market for health. So the first issue has to do with information. So again, in our session we looked at asymmetric information, where 2 parties to a transaction have different information. It's not the same. So in the care market there is this problem of asymmetric, or termed here, imperfect information. This is particularly where doctors might know patients' full case history, full lifestyle choices, etc. And patients don't have full information, healthcare procedures, healthcare benefits, and what's out there. So after you're essentially buying knowledge and information. The vast majority of cases when we go to the doctor doesn't actually do anything. The doctor talks to us, listens to us, examines what's going on, and then tells us what to do, to go and buy a piece of medicine, to go and get medical advice, etc. They were just buying the information from the doctor. They knows what's out there, knows what can help us. Do it ourselves, we wouldn't really have to go to a doctor. There'll be a huge range of information that's out there, a huge range of medical products that are out there. It's impossible for every individual to know this. They tend to be buying this knowledge of doctors. They go through the 7, 8, 10 years training, then have all the experience, the experience of seeing patients, and we're essentially buying that experience and knowledge from them. Because they lack medical experience, pills then assess and evaluate doctors. The doctors tell us something, take it at face value, reason to doubt the information, the advice given to us by doctors, because we're not in a position to do so. Generally, we won't go to 2 or more doctors. We go to one, get a piece of advice, and then act on it. Particularly if it's a minor or a relatively low-level healthcare issue that's involved. To be the case that we don't know we're having good or bad service from our doctors. Our doctors are good or bad. So there's potential for doctors to in what would be malpractice. But this explains why government takes a role in licensing doctors and regulating medicines. So you have to have a license to practice medicine. You can be struck off the register for years malpractice. You can have license to practice revoked. When it comes to medicines, they go through a very intensive regulatory and test process before they can get to the market. That they actually do what it is they claim they do, and can make false promises. I don't want to have effects that are even worse than the medicine that's sold officially has gone through a fairly intensive regulatory process. This is done by the government themselves. So next you have the FDA, the Food and Drug Administration. In the EU we have a similar office, licenses drugs, clinical trials are undertaken, tests are undertaken. See how a drug actually has medical effects, significant side effects. So eligible to be sold and must go through those. So this is the government, in a sense, protecting consumers. You could, the protection slows down the ability of certain medicines, so companies didn't have to go through this. They might be able to get products to market quicker, So likely that people would be safe, would be safe if you get the drugs to market quicker. But then all drugs went to market without testing. This lies a bit. So the balancing, the cost of the regulation, or benefits of the regulation. So the regulation, obviously, that the drugs are much lower in getting to the market. You get 5, 7, either in years to get through the full regulatory process. So this illness might be a lifesaver, but who becomes critical during those 5 to 7 years will have access to the medicine of the regulation. There's the benefit products get to the market that actually do harm. They can be lost of lives. So it's about balancing the cost and benefits between the two. So the government has a role to play as making the correct balance. So imperfect information has a huge role to play in our markets. Information patients know about themselves, information doctors know about medicine, information then they come know about the medicines that they're offering. So there's huge imperfect or asymmetric information in the market for health and leads to widespread market failure, and this in a sense justifies widespread government intervention in the health market. A key that's absent in the healthcare market is competition can be absent. Perfect information, the effective degree of competition. Certainly not decided between doctors on the basis of price. The last thing I'm going to ask is about the price. You're looking for policy and readiness of the service, action availability, raw and price. And also you can compare across services. If you have an injury, if you have an ailment, if you have a disease, that will be treated and hopefully cured by a doctor. So whether the service would or could be better elsewhere. If the same disease again, would you get a better treatment elsewhere? Difficult to compare. And also difficult to compare across individuals. One patient can say they had great treatment after another person will say it was awful. If they presented with what appears to be the same symptoms, there's different personality traits, different visual symptoms, different responses to treatment, etc. But it's difficult to compare across services. And it's not a case of television, so does the television work? Can you do the sharp quality, etc.? Is the sound any good? These are generally the same across all individuals. You look at the television and you get fairly similar judgments. Yes, when it comes to health, two can use the same service, be offered and given the same service, or reach different conclusions about the quality of that service and their personal expectations, their personal circumstances, in response to the treatment. Also makes it difficult to class services. So choosing between doctors is quite difficult. You can't get third-party comparisons. What is appropriate for you may not be too easy. And the doctors themselves limit the information in the market. Up to recently, doctors had a full code, not advertising. So built into the Irish Medical Council, their guidelines for GPs showed what they could do to advertise their premises. And it was very, very little. A bright outside the door, they dictated that the writing had to be black, they dictated the size of the letters in the brass plates, and that was the extent of the advertising. In practice was being set up, it could take a short quote in the classified ads of a local or national newspaper, things like flyers, advertisements in newspapers, in television, posters, etc., were all banned and outlawed by the Medical Council. They believe that doctors should promote themselves on the basis of quality, not on the basis of advertising to patients. But the illegal by the competition authority, competition authority forced the doctors the price they would be charged for consultation up in the waiting room. So that is a requirement of governments to get the information out there. The government intervention in the market because don't have the price information, so that's out there. But it's the removal of the formal banning advertising doctors, most general practices still hold the informal rules. No widespread advertising, GP or medical services, because of the history built up through time. When it comes to competition, particularly in rural areas, people don't have a large choice of doctors to attend. 1, 2, or even more parishes could be serviced just by one doctor. One GP could service in 3 or 4 different parishes. It could be a distance of 15 or more miles to the next GP. It's unlikely that people would that distance and would use the local GP. And they need to be divvied up on a geographic basis. And cover particular areas where you'll see doctors in competition, where the population isn't large, and patients tend to stick to geographic regions or doctors. In areas it's slightly different. We do tend to have the family doctor. Everybody goes to the same GP, the same doctor, the same practice. Not like most goods and services where people chop and change different suppliers. When it comes to doctors, there is a sense of continuity, loyalty to a particular supplier, and terms of information that may or may not be the appropriate choice. Medical industry, when it comes to hospitals, there may be absence of the profit motive, and the motive drives the behaviour of most participants in the market economy. But if motive is absent, then it becomes the motive. So not for institutions, not viewed their incorrect objective as minimising the cost of delivering medical care. So when it comes to the production of goods and services produced at the lowest cost, use of resources, yes, we were looking at and labour, capital, and etc. as the factors of production. Whatever is used to make one good or service can be used to make another. More and more resources that go into health, less and less is available elsewhere. So resources are in a sense being wasted in the healthcare side. These are resources that could be used in other areas. There's an absence of the profit motive. There is all state-run hospitals, particularly in Ireland, and in all children's hospitals, of which we were learning. What is driving the behaviour of the in the hospital market? I could set it up and have for-profit hospitals to easily respond to incentives for efficiency, being the best use of resources, but hospitals minimising cost is getting the service provided at the lowest possible cost. Is the rare model something we want to apply and adapt to a hospital setting? Here wouldn't be the case. Issues with efficiency, we want it to come at a cost of quality. So whether it is or isn't the profit motive are problems. In the of it, resources could be wasted. In the presence of it, quality would be compromised. So it'd be quite difficult to get the balance right. What sort of services and what quality and level of services to be provided to people in the healthcare market. So again, the information problem and distinguish between the performance of each. Where we get the best care, where are the best health outcomes, and what is the patient given the best treatment. So it can be quite difficult to determine. Are you in a not-for-profit institution where maybe more resources that are being underutilized, or a for-profit institution where there might be fewer resources, but that maybe they are being overutilized, and they are being stretched. So profit motive as a whole. Different to most markets. So we mentioned 5 keys to markets in our previous session. One thing that popped up was third-party payment. Party is somebody outside the transaction. So a doctor and a patient. You have a hospital and a patient. You have a patient. But in lots of cases, it's the patient who pays. It's a third party. So there's in a sense inside from the service that somebody else is paying. So for most goods, the consumer pays the full price. Because the consumers use the benefits of the good agrees with its cost. Consumer, when the money has to come out of their pocket, we can take it as they'll take and purchase product best for them. So for health, since they're largely insulated from cost considerations, combination of government spending and private insurance. So paid through the individual's insurance. It could be paid through the government spending. The consumer, the patient, isn't facing the full cost. So their cases may differ. Look at a situation, say, where a driver goes to a car sales room. The salesman says, look, the government is paying for your car. Go in and choose the car you want. What would the driver make into choosing the car? They can go into all the cars and choose what car is they want. Well, if somebody else was paying for a car I was choosing, I can buy and get a top-of-the-range car, all the bells and whistles, all the trimming, all the extras, as much as possible. Just weighing up the cost and benefits. All I can see are benefits. The more the car, the more trimming, the more extras, the better it is for me. So I go for the top-of-the-range car with all the add-ons. When I go to a car sales room and they're coming out of my pocket and tells me that this is the car for me and for the one with all trimmings, all the extras, the top of the range, I know I'm going to consider what benefits all the extras, the top of the range car. Do we really need everything goes with it? So how much extra does it cost? Again, what benefits you get? Do a calculation, a cost benefit, and whether the good is actually worthwhile purchasing. And leave with the car that's most suitable for you. And that may not be the one top of the range with all the bells and whistles. And my mid-range car just has a sunroof. Don't need the pattern built into the system. Don't need the alloy wheels. Whatever it might be, when I'm paying for them, I'm much more likely to be more concerned about the cost for the benefits. But I want a car to get me from A to B, and all the bells and whistles don't necessarily make it that any better. But where I'm not paying for it, I may as well go for all the bells and whistles. Like the healthcare market, much the same can happen. Consumers have the incentive to be cost conscious. So you in your pocket and a doctor says there's two possible treatments. One has a 90% chance of success, it costs €10,000, and one has a 92% chance of success, it's €50,000. If they're paying the money from their own pocket, they'll go for the cost €10,000. That again is very, very small. You're paying 5 times as much for just a 2% increase in the probability of success. Where the doctor says this is covered by your insurance, or covered through the medical card, or it's covered through a public health scheme, and you're between the 10 and the 50,000, then we assume that most patients would go for the 50,000 treatment. Assuming it to be better, assuming it to be more worthwhile, and because they don't have to consider the cost. So it's just a marginal increase in benefit, they will actually go for it. So you may end up with a case where somebody walks into the car showroom, walks the most expensive car, and most suitable for their needs. So in the healthcare market, much the same can happen. So lots of our healthcare is paid by a third party, through medical cards, through public health, through insurance. Nobody else is paying. So when it comes to patients, they'll generally try to take and get as much as they can, and that's only rational. And also the issues of the doctors forcing supply on the other side. If doctors what a fee for service, that not only have patients an interest in getting as much healthcare as possible because someone is paying, doctors have a vested interest in selling as much as possible because they're more money. Services sold, the great income earned, so that the doctors can undertake procedures that may be medically warranted simply because it increases their income. And a patient isn't too concerned because the patient is in pain. If the doctor tells them this is what they have to do, they really go for it. If it's coming out of the individual's pocket, they might be a bit more cautious. So patients, when it comes to health, tend to be risk averse and they need test or treatment to protect their health, regardless of weighing up the benefits. These problems are exacerbated by the fact that a third party pays the costs. So it can be difficult for the third party to monitor what is actually taking place in the doctor-patient relationship when they're picking up the tab. And then types of failure, which I'm sure has been covered elsewhere, are the insurance markets. So failures in health insurance that justify government involvement. So you have moral hazard, maybe people changing their behaviour because they are insured. Taking undue and unnecessary risks because insurance to pick up the tab. You're probably in the insurance market of adverse selection. The insurance is voluntary. Those who take it are likely to be those who will need healthcare services. So the companies suffer from adverse selection. And the third party payment, you're going to suffer from excessive expenditure. Where it's covered by insurance, the patient is likely to go for it, regardless of whether it's beneficial or not. So the companies have difficulties in monitoring what shouldn't be undertaken. So these are a number of market failures in markets that wasn't justified government intervention. The keys of the market we outlined in the previous session, these can largely be absent in the healthcare market. So government intervention earned it. Market failure, so a health system, say based on private health insurance, will be costly, not everyone will be covered, and very bureaucratic. It's only in an office making a decision. Governments can fail too, so failure. So politicians and civil servants have their own motivations. So politicians obviously want facilities and services provided in their local region. So they have different justifications, different decisions. It can be government or political failure. Especially power, the fact there isn't enough to go around. Externalities, both net and positive, and with information that helps know fully what's happening in the healthcare market. So not if you disappear, the economy or health system is run or regulated by governments. These problems still exist, so still face scarcity power. They might have huge budgets, but they can provide everything to everybody. There might be the ability to get information out there. Still doesn't prevent problems from happening in the public healthcare system. In case there are new high-profile cases, situations, public health system let down the patient it's due to serve. Information problem. Are the patients fully aware of some of their problems? And we have some occasions, particularly in relation to women medicine, where patients were turned down by the system, where certain procedures were necessary, and found out that such procedures were not necessary. And there were opinions of a particular doctor operating to a different set of belief values to the rest of society. Challenge confronting the health service of allocating resources. How resources, the limited resources we have, to the needs of the population. There's a limited amount of needs and only unlimited ways of saving it. So there's no good asking patients who pay something for everything or for treatment and will demand more of everything. So this was local hospital services in Ireland, with teams, with marches, with demonstrations, all to maintain local services for population. It is hugely understandable that people would want services provided locally for them. The public sector are not borne by them. The cost is borne by society as a whole. An A&E unit or a local hospital or a care treatment, small regional town. It's not the small regional town that pays directly. The cost is spread and dispersed through the full society. So not the benefits, and here they look for the benefits, but they're not incurring any of the costs. There's no extra or additional cost. the taxes wouldn't be anywhere larger or greater if medical services were continuing to be provided in a particular local or regional area. So patient groups will want more of everything, and that is understandable. The issue is that this must be made with a certain and fixed amount of resources, and all demands cannot be met. Some demands must go unmet, and there's a decision that must be made. So we have the Health Service Executive, the HC, and essentially their job to run, manage the healthcare system, and they must resolve this dilemma. They must decide who gets what type of healthcare and who defend for themselves, or who travel longer distances. Decisions have to be made. We do not have unlimited resources. The resources must be allocated. So the issue of determining the best way of allocating those resources is the dilemma the HSE face. So they're trying to choose the best way. Don't guarantee that they know the best way. Their choices could be wrong. So they're looking to, in a sense, aggregate and centralise many of the provisions of care in Ireland. And that was based on international best practice, international evidence. When we were dispersed system, patient groups are arguing and promoting would be the best. But we cannot have both with huge centres of excellence, centralised care, feeding huge numbers of patients, and much more localised provision of care in small regional towns. Choice of one or the other. With regional provision, we cannot have centres of excellence. If we have the centres of excellence, we can have the regional care. So it becomes a choice. So each government-run system, these are things that have to be overcome. So what is the target of your healthcare system? What to do? Go about, in a sense, making some of these choices. The target of a healthcare system would be to improve the health of the population. And over the last 250 years, the population has increased hugely. The simple measure you must look at how health has increased is life expectancy. The 33 average life expectancy. If he wasn't crucified as a man, people in their 40s and 50s would have been quite unusual. People in their 20s would have been quite usual. And life expectancy did not increase significantly throughout 1,500 years. In the mid to low 30s, for more than the next 1,500 years. It really has been only in the last 200 years or so that life expectancy has increased. And even 100 years ago, life expectancy would not have been much beyond 60 life expectancy. And this increased over the last number of years. In fact, the standard pension age of 66, etc., was introduced in France in around the 1870s, when 65 was higher than the average life expectancy. It was that everybody would reach 65. It was just seen as to introduce the pension for those people who reach this particular age. It was to be introduced not based on life expectancy, age based on the proportional number of people who would be beyond 82 or 83. Average life expectancy in Ireland, which for males is in the mid to low 70s and for females in the high 70s. Health of the population has increased quite dramatically. And it's now that 50% of all male children born at the moment, 50% of them will reach 100. One out of every female born in Ireland will reach 100. The expectancy has increased and continues to increase, and much of that is down to advances and improvements in healthcare systems for health, provision treatments, awareness of infections, awareness of contagion, and awareness of particular illnesses and what causes particular illnesses. So there were illnesses before which wiped huge sectors of the population, being brought under control. A number of illnesses at the moment, and that maybe over the next 20, 30, 40 years, cures for them could be found. Cancer, the big C, is one of the largest killers at the moment, but progress being made in controlling the disease, or matter the cure as of yet. It's not plausible that could happen in the next 30 to 40 to 50 years. So the health system should allocate resources to improve the health of the nation, to be responsive to the limited demands of the population. Healthcare needs can change, health needs can vary. The healthcare system needs in some way to be responsive. And the need to protect people from serious financial losses because at the start of this session we said that there's a different type of product. People need more than want it. If they don't get it, they may die. But healthcare is also hugely expensive. Surgery is hugely expensive, some treatment is hugely expensive, and it also has an element of time involved. Being in long-term care is very expensive. So they can run to hundreds of thousands, and very, very, very few people in society who could afford to bear the cost of that. Systems must be able to provide a serious illness care to people who need it without imposing huge financial burdens on them. The cost must be spread across society. Either a tax finance system where everybody contributes based on their income, or through an insurance system where everybody contributes through insurance premiums, but only people who need it actually use and benefit from the system. And the premiums are actually common across individuals, risk pooling across individuals. When it comes to financing healthcare at the macro or aggregate level, there are a couple of issues that must be addressed. Are here 1, 2, 3, and 4. Efficiency, effectiveness, and sustainability. So in the healthcare system at macro level, these must consider. So in our proposal under the new government, it will be going through changes in healthcare system and operators that will move away from the tax finance system and the tax finance system that we had from all history, moving towards a social insurance system. Some of the issues that must be addressed the new government looking at it. So it has to do with fairness. How fair is the what is distribution of cost? Who's providing the funds? Who's providing the resources? Distribution of the benefits. Who gets what? Is it card? Is it income based? Is it treated equally? And who decides who gets in? It could be financial barriers, but also access in terms of waiting times, waiting lists, mechanisms hold certain people back. So it is a huge issue. Who pays? Who benefits? So at the moment that Ireland has a very inequitable system. So we do, or even a three-tier system, which was with private health insurance, were considered to be at the top of the tree. Those medical cards who have access to a certain number of services, and any health care covered at all is very fair. And the plan is to try and change this. Their views about whether the system is fair or not. Those who have no medical coverage, in most cases choose not to do so. Give the card is distributed on an income basis, means tested. So those with a certain income threshold automatically get a medical card. So 25,000, 26,000 income per annum. Most of those without any health coverage tend to be young people, higher earners who choose not to purchase it. And purchase health insurance, again, the higher earners, but that's older. So their mid-30s on tend to be purchasers of insurance. People get married. So A is an important issue, the fairness of the system. The important element is efficiency. How resources are used, how they're allocated, what they generate. An appropriate level of healthcare provided, given the amount of resources that are used, and we pump huge amount of resources, financial resources, into the care system. The second largest government expenditure item. The Department of Health and the HSE spend 15 billion per annum. So huge amounts of money are spent in Ireland. So the issue is what productivity and what the output. The number of patients being treated, the number of procedures being offered, and resources. Are resources being fully utilised? Are machines being purchased and not used? Are doctors, nurses, and other medical staff being fully utilised? Is the system designed in such a way that the most can be got from it? Efficiency is important, particularly in the public system. We don't have a for-profit motive, helping to ensure that the system is efficient. Huge problems with the health service executive in Ireland. One high-profile, I can't think of the name of it, the head of the human resource function, HSE, has about 2,000 people. He is there just before Christmas. The HR function, the HSE, could operate effectively with 800 staff. So he can have 1,200 too many staff. So the resources going into the HR unit and the HSE, but the private sector output from them, those could be used elsewhere, could be to more frontline services. So it is important. A third concept is effectiveness. What outcomes that actually result from the care, the number of patients, number of treatments, the health provision actually is effective. So what's the impact on the health status of the population? And our health is improving, measured by life expectancy, measured by mortality, measured by infant mortality, measured by diseases, etc. And the healthcare is improving in Ireland. So our system actually is quite effective. It could obviously be more effective, but quite effective. So the first two, which are dominating the debate thus far, and pretty soon we'll see number 4, sustainability enter the debate. Enter the debate large-scale way. Ability is, does it have economic viability? Systems survive into the long term. And this is true for most countries. An aging population. As older, their healthcare needs increase. So this proportion of older people increases. People needing healthcare services increases. So fewer people are productive or working age to provide resources for those who need it. So equality is important. In the first case, in a new but not a huge issue, we have a very young population. In fact, going through a baby boom at the moment, that some of the highest number recorded in Ireland are recorded at the moment. So in 2009, 2010, record numbers of births. So it's 50, 20, 25 years. It's unlikely to suffer from the problems of an aging population. We will have more older people, but we will have more younger, productive people. Countries, this is a far more significant problem. Countries like continental Europe, France, Germany, Italy, etc., US, Australia, Japan, all are the consequences of an aging population. The proportion of people over 65 is getting larger and larger. As people live longer and longer after retirement age, the healthcare requirements of the population are increasing. So our resources available to provide them. So now we have 5 workers for tax and insurance premiums for 1 per 65. What if it drops to 2? And 2 workers sustain 1 person over 65. And these are problems some countries face. So they need to design, replan, reallocate their systems to cope with this. Some of the issues that arise in planning a healthcare financing system. Is the system fair? Is it efficient? Is it effective? And is it sustainable? Design, consider, and plan how it's going to fit into your system. The issue at the moment, I suppose, has arisen as a history. There are changes that can be introduced, and this is what the current government is introducing with their care proposals. Clearly, equity is one of the issues that they see as being hugely important. How to go about paying it? Where does the money come from? The healthcare system. So our pockets. You can have payments for individuals. So go to a GP, go to a chemist in Ireland, go to a consultant. For some people, they pay directly out of their pocket from the general wage income, and they for healthcare as if they pay for any other goods. It's from employment-related benefits. Your could provide health services, your employer could provide health cover. Not a huge issue in Ireland. There is some employment-related benefits, but most are done through insurance, where the employer pays for the insurance. In countries there would be employer health. So some large companies actually would have a unit, an employee health unit, maybe a nurse, doctors. There would have to be the health of the employees that might even extend to families. So through the employer, the government financing through general taxes, so government collects taxes, state taxes, income taxes, capital taxes, collect pot of money, and off a certain proportion of that for healthcare. Many markets are based on the principle of insurance, so you can treat private insurance. But if they have healthcare needs, can choose to have private health insurance. Healthcare needs are met by the insurance company. And some countries, particularly European countries, have introduced compulsory social insurance, where the funds for health doesn't come out of taxes, it comes out of a compulsory social insurance which everybody pays into. And this is sort of the core of the new Fine Gael proposals for the Irish healthcare system. There would be social insurance, not so much a tax-based income, it's an insurance premium. So that younger, older, healthy, unhealthy people contributing, and that the contributions of those who don't need health care sets the that must be provided to those who do need health care. And there is growing a new area of providing health financing through savings accounts. And one of the best examples of medical savings accounts is the Singapore system, about in Tim Harper's chapter. And it may be something that you'd be introduced and exposed to during the year. We're not going to go through it in any great detail here. So the four are some of the important ones, and the fifth one there, medical savings accounts, maybe are becoming having their role. So you have out-of-pocket payments, you have employment-related benefits, government and insurance, and it's just under 80% of financing for healthcare comes from general taxes. The government gives to the HSE and Department of Health. Percent comes from private health insurance, HI, Quinn, Vivas, etc. And 5% comes from out-of-pocket expenses. So paying directly for GPs, paying directly for medicines, etc. Make the remaining benefit. So those are 3/4 of the health financing in Ireland comes through general taxes. So the change of that over the coming years. Just look briefly at some different macro models in a healthcare system. Ireland, we're kind of stuck between a couple of these at the moment. We're not 100% government finance system, nor a system based entirely on private health insurance, nor a system that requires full payments out of people's pockets. Health services model in the United Kingdom, 1% financed by general taxes. So cradle to grave, whatever you get in the healthcare system, in through the state. So Gs in the UK are all public servants. GPs are entrepreneurs running their own business. In the UK model, are public sector workers. They're given particular areas, they're given particular patient lists, and group they look after. There's competition and there isn't choice. They're run by national trusts, and health is provided in the grade to run the system. Then you have different insurance models. So you have the national health insurance model and the social insurance model in Canada are quite similar. And this is the compulsory insurance. Every purchase. So they're only earmarked for health. So it's not dependent on an allocation from government. So government health could rise or fall based on economic climate, based on tax revenue, etc. Based on other political decisions. In this insurance model, the premiums are collected and the so that the system deals with the healthcare needs of the population. So the premiums based on the healthcare needs of the population. So it's social insurance, and everybody has to pay some There are some proposals for people of low income or no income, their insurance premiums paid for by the state. So it's not just somebody on €20,000 a year facing the same bill as somebody on €100,000 a year. And in fact, in many cases, the premiums are income related. A certain proportion or percentage of income goes on the premium. So again, you have higher earners subsidising lower earners. On the basic system of social insurance, there's a fixed level of care, and then you go above that, you can purchase voluntary private insurance. So it's for the bells and whistles, individual room, particular treatments, use in hospitals, in hospitals. You purchase your private health insurance, and that covers those, whereas the insurance covers basic healthcare needs. So it's setting a standard above which everybody is provided a particular level of care. If you want something above that, you pay yourself. The US, the system is almost entirely based on voluntary insurance, both social insurance, health in the US. The insurance is through voluntary insurance, and their whole host of health maintenance organizations who offer health insurance in the US. It does appear to be a very bureaucratic and unwieldy system, and the US system is entirely market driven. But that's entirely the case. The US does have huge public health systems where they purchase for individuals and leading to some of their political and fiscal problems at the moment with the government debt and the debt ceiling and the annual deficit of $1.5 trillion that the US faces. So the US has Medicaid and Medicare. So the US offers health care for the very poor and the old. So these are two publicly run schemes that are based on private insurance, but are basically coming from the state. So Medicare and Medicaid are huge and offer substantial benefits for the very poor and the sick elderly. And so it is a huge provision of health care in the US to veterans. So the army get their health care provided by the government, and there are hundreds of thousands, if not millions, of veterans in the US who use the Army healthcare service. And if you look at the US, and you might argue it's entirely market-based system, over 50% of healthcare expenditure in the US actually comes through the government, through Medicare, Medicaid, and the provision of services to Army veterans. So apart from those 3, 4, 5 years in the Army, as a person, they have healthcare needs provided for life. So it's an expensive procedure. And then, as I said earlier, the Medicaid accounts are used in the city-state of Singapore. You might be looking those some during the year. But again, because of the huge cost of some healthcare services, the med savings accounts must be backed up with a form of insurance. People never save enough to cover most expensive healthcare procedures. So insurance in the Singapore system, what happens in a very small number of cases, it happens when the healthcare runs to several hundreds of thousands, and it could be covered by savings. So it's called catastrophic insurance. If you need brain surgery, lung transplant, long-term care, insurance is there. Because it only covers that arise in a very small number of people, the cost is quite low. So when looking at the amount of resources that countries devote healthcare, we see differences that emerge. Is the healthcare expenditure across 6 systems we've mentioned here in the previous slide as a percentage of GDP. So it's a percent on the start about the mid-1960s and goes up until about the year 2000, and most of these will continue as they have here. Then we can see that most countries were grouped quite close together back in the 60s. 4 or 5% of GDP devoted for healthcare. What's important here is that more resources the country devotes to healthcare than it has to devote elsewhere. So these percentages increase, the percent elsewhere have to decrease. Only is 100% of GDP available. So you go from 10 to 15% to healthcare. It must go from 90 to 85. So these percentages are quite important. I see the range of the curve the next 40 years, and the one that stands out quite clearly is the US, which has got a situation of maybe 6% of GDP, up towards 14, 15%, and in recent years has continued to rise up over 16%. Sixth of the US economy is devoted to healthcare and increasing. The UK, you can see, is much lower, but it has remained around 8-10% and has been increasing in recent years. You can see the one that's gone in the opposite direction is the savings system. Maybe there's some merit. The medical savings accounts that kept their health insurance around 3-4%. In the other case, we're around 10%. We're well US and probably close to the European average. It's increased in recent times, close to the EU average in expenditure. 10%, so that sector makes up around 10% of the economy. So this is quite large. You can see the importance that different systems make, how much of country resources are devoted to healthcare. What's obviously the only criteria which we judge. If US is spending the most, with S, if poor is spending the least, maybe worse. The care is as important as the efficiency. So the more resources are being accumulated here, cases are getting better outcomes. So the numbers we have here go up to about the year 2000. 2000. The World Health Organization, actually a comparative of national healthcare systems. It must be a very complex and costly job because they haven't done it since, and other organizations are providing rankings of healthcare systems. So that's slightly dated. It is an 11-year-old system. Most systems haven't changed in the last number of years. So we add the ranking. Systems are the best. Are the top 10. Thing to note about the top 10 is that it's dominated by European countries. So 1, 2, 3, 4, 5, 6, 7 of the top 10 are European, and some are quite large countries. France, Italy, Spain, etc. All appearing in the top 10, putting quite large amounts of their net income to health. So 11% in France, nearly 9% in Italy, 8% in Spain, and so on 10% in Asia. So large amounts. Health expenditures capita, they are quite large. The French spending €4,000 capita, the Spain spending nearly 3,800, Italy nearly 3,000, and over 2,000. On a population basis, spending huge amounts of money on their system. I note about the break between public and private. When we said it was around 75-25 accounts. That 7% of the money comes from public sources and 20% comes from private sources. So the government, private being private insurance or out-of-pocket expenses. If you look at most of the top performing health systems, 8% public in France, 77% in 84% San Marino, 80% in Andorra, 72% in Spain, 77% in Austria, 82% in Japan, 2000, most of the top-rated systems, and most of the expenditure coming from the public purse. If you look at the top 10, only one country has the reverse ranking. Which those private expenditure dominate public expenditure. Start Singapore, where one came from the state, and 2 came from private. And this private expenditure comes from these medical savings accounts. So these people are spending their own money, going for the gold-plated trims and pistols approach, going for what's best for them. So therefore, actually look at proportion of their expenditure of GDP. It is the 173rd largest spender in the world as a percent of GDP. 172 countries devote more of their resources, but Singapore came in sixth. So by such a few amount of resources, it's actually able to get quite a strong system. Singapore is a rich country, even as a proportion, it comes 173rd. If you look at a per capita basis, it comes 35th. So there are poor countries who devote a greater proportion, but a proportion of much lower income. They just don't have money to spend. Singapore is already a rich country. So on a percentage basis, 5%, 3.5% of their average income brings up to 35% overall. Per capita basis, and we move up a lot. So yeah, we call it into other countries. You can see Ireland in 2000 came in and with our expenditure on GDP basis, and on average, we commit 38 amount of GDP to health, about 10 times, because we were a wealthy country back then. We're the highest spenders per capita, not getting the value per capita. There are countries who's more than us on a per capita basis, but 18 countries who are better than us health outcomes basis. In this case, you can see the rough percentage I spoke about, 78-22. Most of the money is coming from the public purse rather than from private sources. Brazil is the country that spends most. It was ranked 37th. Nobody spends more than the US. $1,714 per annum back in 2005. 15% of their GDP goes in healthcare. Yet ranked 37th. On health outcomes based on equity, based on access, based on efficiency, their health system was relatively poor. In this case, we're moving to the Dutch system, and it mightn't give much policy. The Dutch was only ranked 2 positions above us, but the system has been revised substantially since then. The whole Dutch system was based on S-type system. They have revised it to social insurance and changed it completely, and the system has moved up these years, done in the last few years. So we're not just moving from 19th to 17th. The Dutch system would be ranked in the top 10. But back in 2000, under their old system, they were 17th. In terms of expenditure, spending amount of money isn't a guarantee of positive healthcare outcomes. So the US spends most. Countries like Singapore spend very. So studying their systems can be quite important. Look at the macroeconomy. The size of the healthcare system is important. It's not the sole determinant of whether your healthcare system is effective or not. There are different issues involved. So getting the equity, the efficiency, the effectiveness and the sustainability is always important in your healthcare system. A quick run through health macroeconomic issues. We've touched and skirted around the role and rationale for government involvement in the healthcare sector. Very few healthcare systems have no government involvement. In fact, those that are most effective, most efficient, most equitable tend to have largest government involvement. So while private markets do work best in many cases, when it comes to health, there is a suggestion that the government is vital to the effective functioning of the care system. So we'll leave it at this session. I plan to do one more. We'll just go through how to help and take the assignment that's due over the next couple of weeks.